Good afternoon and Happy New Year. It's good to see you all here today. Hard to believe it's 2026, but I think it's a good thing. And thank you so much for coming in today. I know some of this will be people attending quite a bit online as we're just adjusting back into coming into the building, although many of us have continued to meet over the last couple of months. As you know, TCB is a committee that meets year round. So I just want to say thank you for being here, and I'm really looking forward to the discussion later today as we discuss the eating disorders. I think this is an area that definitely needs a lot of our focus and our attention, and so I'm really looking forward to that presentation. And so I'll toss it over to Claudio and Senator Mar. May be online. She is online. She is definitely here with us there, doing a little bit of double duty, but we're happy to see you and Happy New Year, Senator Mar. Do you want to jump in or?
Sure, I'll just say
Okay.
very briefly, welcome everyone. A new fresh start to 2026. We're excited. Today kicks off some of the work that we're going to be doing on formulating policy recommendations. We're going to go into a short session, so lots of work to do in a shorter period of time, but I think we're ready for it. So Happy New Year, and look forward to the meeting today.
Senator Mar, would you like to say anything? I see you on.
Sure, just a quickie. I'm also glad to be back with everyone, and at the same time looking forward to the conversation around the policy recommendations and the fact that we're talking about the disordered eating, which I think is a key piece of our behavioral health concerns that don't always get the attention it deserves. So thank you so much for having this conversation with us today.
Okay, thank you. And we're going to get started. First, we need a motion for the acceptance of the December 2025 TCB meeting minutes. Okay. Can I get a second? Second, Jeff. Okay. Before we approve any adjustments, revisions to the meeting minutes? Okay, seeing none, can I take a vote to acceptance of the meeting minutes? Everybody in favor? Okay, thank you. I'm going to now give the floor to Emily.
Good afternoon, everyone. Happy New Year. I'm going to pull up the agenda quickly to get us started. So today I will be giving some administrative updates on the work groups and some of the studies that the TCB is tasked with. And then we'll go into potential 2026 legislative recommendation concepts, ideas. And as Rep. Exum and Senator Mar mentioned, we'll have a presentation on disordered eating and their policy recommendations. So we are having a collection drive right next to me. I have a big basket. If anyone does have any additional items, feel free to come up to me after the meeting. The donations will be going to the diaper bank in Brian's Angels, which is based out of Bristol. And I'll put the information regarding Brian Angels in the chat in a second. So looking ahead, our next meeting will be February 11th from 2 to 4 at the LOB with a Zoom option. This will be a voting meeting potentially for the 2026 session. And I also want to highlight that the morning of the February meeting, the Community Voices Work Group will be having the part 2 of their CVW Summit. This was originally scheduled back in October, but we rescheduled for this upcoming February. TCB members and designees should have received an email and an invitation from me in a hold from 10 to 12:30 that day. If you do plan on attending, if you could please accept that invite just so we can get a head count. I will be sending an additional email. But I also wanted to give the floor quickly to Adriana Ramirez, a CVW member online, to just kind of highlight the importance and purpose of this summit.
Good afternoon, everyone. Thank you, Emily. Excuse me. I apologize, I'm a little under the weather. But the summit that we attended the first part, and it was so valuable to bring voices together as we're doing these initiatives. And we have separate committees and subgroups and things like that. And it's a way to kind of bring everyone together and be at the table together as a team, even though we have different functions and different strengths, but really just coming together to brainstorm, find where we come from, find those commonalities, and build strength in our strengths, and to be able to build strength in team. The health strategies, they really supported us in great activities. We have not only the CVW group, but we also had families come in as well, and it was a wonderful event. So we're really looking forward to have everyone attend the summit, because it is that bonding and that solidifying of togetherness, to be able to come together fully to continue those steps that we're doing for this TCB initiative, the planning and policy, the work that we're all doing. And it was very inspiring, very energizing, and also just it was a catalyst, excitement to really understand where we come from, who we are, and how we're all going in a direction together. So I really highly recommend as many that can come to the summit. It's well worth it. I think it'll strengthen what we're doing in the different work and subgroups and work groups.
And just want to add one more thing, that, part of the requests that the TCB and many committees like this and commissions and task force have on a regular basis is we want to hear from the voices of those impacted by the policies that we produce. This is your community voice expertise work group. This is your parents. These are your parents who are in the community working day in and day out with the young people who are in need of your services and the work that you're doing here today to increase the access to services for young people. And so, this is, as Adriana said, it's an opportunity to really hear from them, and also to create that bonding sort of relationship for how we're going to work together. So, I urge you to please attend if you can that morning, because it's very critical. And as we frequently say, we want to hear from the voices of those impacted. This is an opportunity to do so. And we will be providing breakfast. So please join us.
Erica, I just want to add also, the families that did attend it was incredible what they shared. It was so impactful. And I look forward to having as many families as possible to join us again, so the members, TCB members, can hear their impact, their stories during that day. Thank you.
Excuse me, can we just confirm the date?
February 11th.
Okay, because I think on the slide it has the 14th.
No, it says 11.
It was changed?
Yeah, I think there was a typo in the original
okay.
presentation,
The original,
but
okay.
yes, it's the day of the TCB meeting. And Amuna online, her hand raised.
Yes, I just wanted to add to what Miss Adriana was talking about. My name is Amuna Patterson, and I just wanted to say especially to the legislators, why you're present at the collaborative voice group is not symbolic. It's very, very essential. Too often policy is created about families without being created with families. And when that happens, even well-intentioned laws can miss the mark. So the CVW Summit is very different. This is not another conference filled with abstract data or talking points. This is a space where family, youth, and caregivers speak directly to power, where lived experience meets, legislation in real time. At the summit, you won't just hear statistics. You will hear the stories behind the statistics. I am presenting my life, my life experience with my whole story, and it will be an honor to have you there present, so that way you can know why I do what I do, and why I take it very, very personal to do with love, to do the work I do, in and out daily, with families, especially in schools and things like that. So I expect everybody to be there present, and it will be an honor to have you with us on that day. Thank you.
Thank you. I'm just going to provide some brief work group meeting updates. The system infrastructure work group will meet next January 20th from 3 to 4:30 in Zoom. And within our December meeting, the work group reviewed and provided feedback on the draft cross-agency data sharing work group language, and reviewed the recommendations from the Yukon Innovations Institutes at this Yukon School of Social Work's Children's Behavioral Health Data Infrastructure Report. And we'll be highlighting that draft cross-agency data sharing recommendation later in the meeting. For services, our next meeting is January 14th from 2 to 3:30 p.m. on Zoom. And we will be getting an update from Jill Farrell at the Innovations Institute on current responses and the overview of data on the TCB Children's Behavioral Health Provider Survey. And we also are meeting as the subgroup for that survey earlier in that week as well. For the school-based, we are meeting next on February 2nd from 3 to 4. We just had a meeting this past Monday where we discussed the draft school mental health infographic. We're currently getting feedback from the work group and others sending out from the work group. And from prevention, that should be January. This work group in December met December 4th, focused on developing ideas for the draft work plan for 2026. The group had originally started working on potential recommendations for this session, but since this is a newer work group, we are hoping to develop these into the work plan for 2026. So the work group will continue to provide feedback for that in the January meeting. And I'm just going to provide more brief updates on the different studies that the TCB has been tasked with. So for the school-based health center study, Tau Youth Justice Institute and the school-based work group chairs met with DPH prior to the holidays to discuss the scope of the study. And we are hoping to release an RFQ for this study in the upcoming months. For the school behavioral health billing, as well as the behavioral health needs and special education students, we will be meeting with these subgroups next week. We had preliminary meetings this past fall with members who had helped work on the legislation, or others who are content experts to develop kind of a draft scope of work and identify individuals needed to help lead the efforts of both of these studies. For the UCC private insurance review, we had just met prior to the holidays in December to discuss updates to provide private insurance billing for UCC, as well as barriers to billing. And the crisis continuum review, this subgroup had met a few times in the fall to evaluate data that is currently being collected. This is what was presented at the December TCB meeting. And the group will reconvene in the next few months to evaluate the fall 2025 data trends, as well as we are continuing to work on the UCC marketing aspect of this study as well. And for the ICAPS, we are working with the Yale Child Study Center to identify funding sources for the study. And for the ICAPS review of models, we are looking to connect with DSS to obtain more updates. So in upcoming meetings, I just wanted to reiterate the mission statement of the TCB as well as the TCB's purpose and kind of correlate with the agendas for the TCB meetings. So I'm not going to go through these next slides thoroughly, but I did bold kind of the sections of both the mission statement and the purpose that are aligned with today's agenda. And I'll just highlight a few here as we're going to be discussing potential legislative recommendations. I highlighted two service delivery gaps and other missed opportunities to advance the state's abilities to offer families a set of streamlined, accessible, and responsive solutions. For number 5, this will be touched upon in our presentation on eating disorders later today. Behavioral health access and outcomes for children of color and in those in underserved communities, such as rural parts of the state. And 7, kind of tied into that cross-agency data sharing language, looking at quality assurance frameworks to maintain timely data analytics to improve both private and publicly operated behavioral health services. So now I will dive into the legislative recommendation concepts for 2026. There were 2 that stemmed out of one from the System Infrastructure Work Group and one from the Crisis Continuum Subgroup, with two potential legislative concepts. So one, as I mentioned, is the cross-agency data sharing work group concept language. And then another one is the development of a sustainability plan for the data quality improvement efforts for the urgent crisis centers. And then further areas for the TCB to consider. The prevention work group had a presentation from the 11920 collective back in December. They provided their legislative recommendations. We had met with the chairs and evaluated the current recommendations and had felt that those are more aligned with the Juvenile Justice Policy and Oversight Committee. The second bullet is in collaboration with ASTAC, explore autism and IDD recommendations, which we'll plan on doing in the upcoming weeks. And then today's presentation from the Commission on Women, Seniors, Children, Equity, and Opportunity, Eating Disorders in Children. So this is the first draft kind of conceptual recommendation background, the development of a sustainability plan for the data quality improvement efforts for the urgent crisis centers. This was highlighted in our December meeting when discussing the UCC's current contract that aggregates and produces quality improvement reports both quarterly and annually. These reports are utilized by committees such as the TCB and the SAC, as well as the UCCs to evaluate current data trends in data and services and establish performance improvement plans. And as just broad conceptual language, we are recommending to sustain or for the TCB to explore a sustainability plan for the data quality improvement reports for the urgent crisis centers. I'm not sure if Frank or Howard has anything to add regarding this, or if anyone has any direct feedback.
I mean, I'll defer to Howard or Frank if they have anything, but I just have some clarifying questions, if that's okay. I'll move forward then. So my understanding is that there's currently an effort to collect data and do performance improvements around the UCCs, and it's been grant funded through the end of fiscal year 26. So I understand this recommendation to be, let's figure out a pathway by which to braid and find, identify resources to continue that work so that the data that we've come accustomed to that's really valuable for us in evaluating the UCCs can continue. Is that what it is? Okay, because
Yes.
I think we may want to clean this up because this feels like it's another sustainability plan for a plan. And I don't think that's what we want. I think we're just outcomes oriented here. We just have collected and maintained this information through grant funding. And the recommendation is to find and identify the resources to maintain that data collection and reporting moving forward.
Thank you.
I would agree. What I had, the feedback I'd given was, I certainly wouldn't be in a position to make, budget recommendations of what we should or shouldn't pay for. But certainly it's our plan to identify a means to continue to fund those activities.
And if I could also, just to clarify, my understanding is that the original funding around the grant that was available was due to expire at the end of December. That has been, thank you, CHDI, also for continuing to work with us on that through the end of June, I believe, through 2026. So we support, as along with, I think, the rest of the group on exploring another sustainability plan for being able to continue to provide that data to evaluate effectiveness moving forward after that. So just to clarify, thank you, Glenn.
Thank you. So I'm going to move on to the next one. And I know Jason Lang online, the co-chair of the System Infrastructure Work Group, is on. Jason, I'm not sure if you want to start this off.
Sure. Thanks, Emily. Yeah, so kind of just to briefly summarize, this is a follow-up kind of recommendation from the infrastructure work group that's based on the report that Innovations did. and some of the preliminary discussions that we've been having in the infrastructure group for the last year or so on the need to better identify and report and make publicly available data about children's behavioral health services in the system. And so this language, I believe, is intended to coalesce a working group around these data issues, and then have that working group advance some recommendations about how we can better collect and report and make available data across the system.
And then, Jason, if you don't mind, I would like to also elaborate that what's critical about this recommendation too is that it does, when you, it's hyperlinked to this where it says, please see additional draft language here is in regards to the who. When we're talking about data, when we're talking, it's very important that we have, for any of this actually work, it's very important that we have the right people at the table to discuss. So the people that are the operational people in each, whether it be state agencies or other specific entities that deal with data on a regular basis and so forth. Because I think when we're talking about data system infrastructure, it's going to be very important that those individuals, whether it be from state agencies or others that are invited to this table and be part of these discussions to identify, to take this report and then see what's feasible and what's not feasible. We can't do this. This is not necessarily like an open work group. It would be very specific as to who's identified to this to participate in this. Not that nobody else can. It's just that we're also looking for specific. Say, I'll just put an example. If we're talking about data of DSS data, then we would need somebody who works with that data on a regular basis. If we're talking about STE data, if we're talking about early childhood data, we need those specific individuals and representation from those state agencies. So just wanted to elaborate on that.
Yep, thanks, Erica. And the infrastructure group started to kind of flesh out a list of potential state agencies that we would want represented. And I also want to say we did also include families and consumers and providers and some others on there that I think have some ideas about how to do this as well.
This is a really good recommendation, and I just want to give credit to the working group because one of the nice things about this is not only will it create an intentional way to collect the data we need and look at how we share data across system, but more importantly, what we do for it, what we do with the data and how it's going to move our policy solution. So I'm particularly interested in the parts that talk about creating robust reporting mechanisms and ensuring accountability. So I hope as part of our thinking here, we're going to be benchmarking. What does success look like? What should be the peer state goal in each of these metrics and categories? And are we making progress year over year? So excited about this work and hope that we keep that unique piece to this recommendation all the way through to fruition.
Thank you. Any other comments? Oh. So if no other further comments regarding those two, I believe I can pass it to Thomas Nutrio and Tiani Zhang online.
Thank you so much. My name is TJ Nuccio. I am the Children's Policy Analyst with the Connecticut General Assembly's Commission on Women, Children, Seniors, Equity, and Opportunity. Tiani?
Hi everyone, it's our pleasure to be here today. My name is Tian Yi. I just graduated Yale this summer with my MPH in chronic disease epidemiology. And since summer, TJ and I have been working with the commission on this initiative on developing legislative recommendation for disorder eating and eating disorders. And we are so glad to have the chance to share the presentation with you guys today.
Great, thank you. And as we are pulling up our slides here, I do just want to thank the TCB committee for allowing us to be here in the first place and present our research on disordered eating and eating disorders. I will just give us a minute as we're pulling this up. So our presentation is broken down into three concrete areas. So we're going to talk a little bit about, first and foremost, what are eating disorders? What is the prevalence of them and the significance? Because it is a story that is often untold here in Connecticut and throughout the United States. And then we're going to talk about our legislative policy recommendations for the committee to consider. So I will kick it back to Tianyi.
Yeah, so before we go into the details, what are eating disorders? So we know that eating disorders are about eating behaviors, but they're not only about eating. They're also deeply connected with emotional struggles around body image control. They're often linked with some of the more familiar behavior issues that we know, like depression and anxiety. So they can basically affect anyone, regardless of their age, gender, race, or body size, and are often misunderstood or overlooked because of stigma or misinformation. So here we want to share a little bit about the difference between disorder eating and eating disorder. So we know that there's a certain diagnosis line for eating disorder, but we would like to acknowledge the broad group that suffers from the symptoms of disorder eating, but doesn't yet reach the diagnosis line. So these groups are often overlooked, both in the clinical service and also in the non-clinical community side of the work. And so TJ will follow this up with the prevalence and significance of eating disorders.
Great, thank you. So as you see here, we have some data from Harvard, the Harvard Strike program. That is one of the nation's leading organizations that has been studying eating disorders and disordered eating throughout the United States. As you'll see on the screen, about 28.8 million people, that's about 9% of the US population, will have an eating disorder at some point in their lifetime. If we're going to break that down by Connecticut specific numbers, that's roughly 314,495 people here in our state. And you know, Tiani and I like to say, take these numbers with a grain of salt. And here's why. Eating disorders are so often underdiagnosed. They're underacknowledged. We're going to talk a little bit more about that as we get into some of our data. And I do just want to say, when it comes to this, most eating disorders happen between the ages of 12 and 25. That's according to Johns Hopkins, and that is consistent with other data that we've uncovered as we've been doing this project. Eating disorders, you know, and this is something we discovered along the path here. They have some of the highest mortality rates among all mental illnesses. You know, that's about 10,200 deaths per year as a direct result of having an eating disorder. We'll talk a little bit more about those numbers as we're moving on in this presentation.
So luckily, we have the chance to be collaborating with regional hospitals in the States, and they are willing to share us with their actual inpatient data. So when we say inpatient, that means the patients with the most critical conditions, most likely emergency care. So these are the numbers for the individuals who need emergency care with a direct relation to eating disorders. So we are seeing an increase, the number almost doubled in the past 5 years, and the number of outpatient also increased over the past years. So a little bit more on the background, we are seeing a surge in the eating disorders for a few of the reasons that are not being addressed in the States. So first of all, COVID-19, our hospitalization almost tripled over the year. And the other two most important issues are the impact of online social media and the cost of diet pills and GLP-1. So we do have some recent updates when it comes to social media regulation, but not yet anything when it comes to diet pills and GLP-1. So later in our legislative recommendation section, we do have one bill targeted towards the control over diet pills. So eating disorder is a condition that suffers a lot from disparities, just like other behavioral health issues. So first of all, gender disparities. We know that women are more likely to suffer from eating disorders, but however, male also represent up to 1/4 of the cases, but these cases are more likely to being overlooked or being missed because of stigma or misinformation. We are also seeing higher cases when it comes to our LGBTQ plus population and with compounded effects in the treatment and their recovery outcome. Racial disparity is also a huge problem when it comes to eating disorders. So first of all, they are having a lower treatment access. And beyond that, we are seeing a clinician bias when it comes to diagnosis. So if we present the same case description to a physician with different race, the physician are most likely to identify the white patient correctly, but missed the case when it comes to the population with colors. And other than race and gender, we are also seeing more prevalent case when it comes to our military populations, both the active army and also our veteran population. So for insurance, eating disorders alongside with other behavioral health conditions are shown to have less coverage when it comes to both the Medicaid and also commercial plans. So we do have a little more when it comes to, we do have a bill targeted towards eating disorder insurance coverage that we would like to share later. So we know that the recent HR1 is, we know that the recent bill HR1 has a lot of impact on different aspects of our lives. And although not directly mentioned, it is closely linked to eating disorders, but we don't have time to go into details about them one by one, but we would love to answer any questions alongside with this. So what specifically are we trying to do in Connecticut? So currently we do have services in the states targeted towards eating disorders. We have treatment facilities, we have research development, but most importantly, they are not only isolated, but also not enough. So what exactly we can do? In the States, we don't have any legislation currently targeted towards eating disorders, and we don't have any working group targeted on this issue. So what are some of our legislative recommendations?
Great. Thank you so much, Tiani. So we would like to break our recommendations down in a couple ways here, but first and foremost, we have the slide because this shows the spectrum of the ways that we are trying to address eating disorders in the state, from awareness all the way to recovery and then everything in between. So our first recommendation that we would like the committee to consider is to require school-based health centers that are in our state to offer an evidence-based screening tool to support early identification of eating disorders. As we've mentioned a couple of times during today's presentation, eating disorders are so often misdiagnosed and underdiagnosed. One of the ways that we know we can get more concrete data and actually understand the scope of the problem is through screening. There are peer validated tools that are out there that can be used and easily implemented. We're actually in discussion right now with the school-based health centers on this and how this would actually look in practice. The second part of this recommendation is to encourage these screening tools during annual physician visits. It's another line of protection that we have here that can identify some of those signals to identify eating disorders and disordered eating in our populations.
So
Jianye, I'll let you, yeah.
Yeah, great. So we know that our physicians are already really busy when it comes to their work. So we would also like to share how we want to implement this without creating additional stress. So for the screening, we would like this to be a two-step process. So we start by rather brief pre-screen questions. There are usually among 3 to 5. And then if we identify any potential risk factors, any positive signals, we proceed for the full evidence-based assessments. And we would like to share more or answer any questions later. So our second recommendation is in collaboration with Harvard Stripe, the nation's leading eating disorder research center. So we would like to adopt their modified version of a model legislation which prohibits the sale for over-the-counter diet pills and muscle building supplements for any individuals under the age of 18. So as we know that the rise of diet pills and muscle building supplements are a huge cause of the rising cases for eating disorders, but currently we don't have any in-state regulation. So we would highly recommend the commission to consider this.
Yes, and for our third recommendation, it is to create evidence-based educational programming on disordered eating behaviors in our middle and high schools. We know that this is often the ages in which disordered eating behaviors start to develop. We need to be getting the information readily available to children or youth around the state in as many forms as we can. I know that there's already programs that are available for districts that they can easily pick up and implement into their existing curriculum.
So our recommendation for, as we introduced earlier, will be focused on insurance coverage. So in Connecticut, our insurance already covered mental health and eating disorder treatments, thanks for our parity law. But in these regulations, they did not specify whether the insurance company can deny a patient's treatment based on their BMI or body weight. So here we would like to have this bill to strictly prohibit any insurance companies to deny or limit patients' treatment using BMI or weight as a standard. So we would like the coverage to be solely considered on medical necessity. Here we have a list of our recommendations, our recommended criteria for the committee to consider. This is followed along and improved based on a similar bill in Colorado. So our fifth bill will focus on the allocation of state resources. So as we discussed earlier, there are many clinical resources already in the states, but we are not so strong when it comes to non-clinical community side of support. So here we would like to encourage for the state to establish more community-based non-clinical support such that we could have a network of service where we can connect awareness, early engagement, and recovery. Other than that, we will also recommend more funding to support our administration for school-based screening. Our seventh recommendation focused on the Connecticut School Health Survey. So we know that the Connecticut Schools Health Survey is a biannual survey conducted for students aged from 9 to 12. They ask questions from physical health, mental health, and also eating, their diet, but there's not a single question that targeted on their eating behaviors. We would recommend that the survey to incorporate at least one question on disorder eating behaviors into the behavioral health sections, just that we could have more data for the states and for our future work.
And our final recommendation is to establish a working group within the Commission on Women, Children, Seniors, Equity, and Opportunity to study eating disorders in our state. Eating disorders, one of the themes in our research thus far, they are evolving a lot faster than we are regulating and we are introducing policies. The eating, some of the trends in which we're seeing that are creating the surge in eating disorders were not necessarily problems of previous generations and in previous years and have evolved more recently. We need to kind of get ahead of the curve, and we think having a working group to really look at these things, study them, and come up with some of those approaches to reduce and for recommendations for treatment of these eating disorders is one of the most valuable things that we can be doing from a state perspective.
Yeah,
And-
so as we said, we hope that these recommendations are sort of like a roadmap. They are from different categories of the care for eating disorders, and together we hope that they will function to create a more thorough, comprehensive care for eating disorders. And we do have another recommendation that we kind of skipped in the presentation, and I would like to quickly introduce that. So, sorry. So in collaboration with our 211, we would like to expand the access and recognition for eating disorders. So this we can do through two steps. The first is to improve the categorization and searchability, and the second is to integrate our screening into their consultation prompts. So this will hopefully help us to transfer the information from the individuals, their family, and our clinicians and government. And that's it for our presentation. And we are glad we would like to hear any feedbacks and questions.
I'd like to thank you so much for this presentation. I can attest to the fact that eating disorders are incredibly complicated. And when you're in search of help in the state, it's really difficult to get it for, I can say for young people in particular, when really reflecting back on how so much of this work started, it started around an eating disorder. It started around being you talk about lived experience. This was the lived experience that my family, a loved one, experienced. And to have a young man in this who's a teenager and not able to find the services and support was incredibly difficult. Ironically, when you mentioned the legislation in Colorado, it really triggered because we spent 3 months in Colorado in order to get treatment. And what this shows me is that your recommendations here, I have to say, I think are spot on. They build, they really do look holistically at a lot of the work that would need to be done as far as screening. The same way we know pediatricians don't get a lot of training around behavioral health disorders, they don't get a lot of training also around eating disorders. So oftentimes the first place you run is to your pediatrician, but they do know the two places, really, in my experience, it was one place that was here, which was Walden, which doesn't fit everyone, and not every, a boy was harder to treat than a girl. Center for Discovery does not look at boys, for instance. So I think that looking at what you have here is incredibly important. One of the things I'm curious about, though, when looking at number 2 with the over-the-counter diet pills and muscle building, have you heard anything about laxatives? Because I know that is a area of big usage within the eating disorders community, and just wondering if that would be something that should be addressed as well, if that's something you've run across.
So thank you so much for bringing this up. This is also something that we've noticed along the line. So this current bill does not address laxatives because they are not being promoted as a means to lose weight. So we are still trying to find the best language to try to control this issue, but as far as this bill goes, it does not consider laxatives.
Right. It may be an area to definitely tap into and explore, because I know it's pretty well used and prominent within that community, for sure. And
Absolutely.
another thing I'd want to look at is when we look at the screening at the school-based health centers, most of our schools don't have school-based health centers. So looking at how we could address what teachers need to know, what other schools, how else they could get information. Is there a way to broaden that recommendation so that we take it beyond just the school-based health centers?
Absolutely. So this is something that TJ and I have been discussing on how can we expand their service. We would love to hear any recommendations from the board. When it comes to teachers, so we didn't have time to go into the details of our recommendations. So we do have a recommendation targeted on the school-based education. So for that recommendation, we have a section where we create educational materials for our teachers and educational professionals.
Okay, very good. I think that would be really helpful as well. And I'm not trying to dominate this, but this is something that I think is just incredibly important, and I'm glad to see you using it. And the 211 piece is also really important, because that's a resource that we call, and it's a really hard space to get responses and get guidance to. It's something that is almost like the Wild West. And there were certain people who would kind of turn away because they didn't know how or where to send you. But I think the other piece that's really, really important is what you talk about, the getting the nutritional counseling and the follow-up. Because once you get to a place of resolution where the child is stable or the person is stable, without proper supervision and nutrition training and ongoing, it took us a year afterwards with it was really, really difficult. That's so important to implement and to hold, or you have this going back, and the relapse rate is very, very high. And so I think that piece of it, and it's hard because especially if a child's in a public school, to have someone monitoring their food and monitoring around lunchtime, if there's that piece isn't there, there's a very, very hard and very difficult road ahead, and the relapse rates are really high. So I think that's really important that we look at that nutritional piece and see how that's covered and how that's supported. It's a complicated disorder, but I'm so glad you're bringing this kind of attention to it. I'll stop there, but there are a whole lot of hands online, and I don't know who was first. Let me start with Rep. McCarthy. I'll start with you. I see your hand here.
Thank you very much, Madam Chair, and thank you, Tianyi and TJ. And I just wanted to share a couple things. I also want to say thank you to Dr. Douglas Patel, who has been partnering with them, a Fairfielder who brings a lot of expertise when it comes to disordered eating, and particularly bringing some of the model legislation and working with you on the diet pills and that Harvard model legislation, I think is wonderful. I think a couple things that I want this group to know is that we actually met yesterday, the Public Health Committee, and to hear these recommendations, and we're going to be continuing to talk. They also didn't share, they're being modest, that they've also met with the Education Committee chair to talk about these recommendations, and I have also, the House chair, I have spoken with her about that as well. Senator Amar and I will certainly be talking about this in terms of some of the public health pieces. I did share that the diet pill piece, as much as I would love to take that up in public health, I think may be a general law issue, and recommended that we talk with Rep. Turco and Rep. Lamar in the House and our Senate leaders. I'm always partial to the House, everyone. It's not that I don't love our senators, Senator Maher, we love you. But I think that this really is an issue that is something that has been overlooked in a lot of ways. And just want people to know that as these legislative recommendations are coming forward here, those concurrent conversations are happening. And I think, as we talked about yesterday in our meeting, to the two of you, there are a lot of pieces. So this is probably a multi-year conversation. So part of what would be helpful here, I think, is, and I'm going to have to leave for another meeting like every legislator does, but is to talk about what this group and this body would think would be some of the priorities within all of these. Obviously, there are different committees, so it's possible to do different things in different committees. But I'm thrilled. And to the two of you, thank you for your work and for the work of this group. And I look forward to continuing the conversation. Thank you. Jeff.
Thank you for great presentation. I noticed that a lot of the recommendations were around awareness screening, which, and you mentioned pediatricians and I think other school-based health centers and others. Increasing awareness, increasing screening leads to further identification, which immediately kind of raises a question about provider network sufficiency for me. So I was wondering if you had any thoughts, and you mentioned in your slides a couple of providers for eating disorders, and maybe I'm teeing this up for Alice, whose hand is up. I imagine that our child guidance clinics and outpatient centers might have some capacity to provide intervention for eating disorders, so I guess I just would love to hear your thoughts about increasing the capacity of the provider network beyond what we currently have, if we increase awareness, screening, and identification, to then also increase the availability of intervention.
Thank you so much for bringing this up. This is also a huge concern that we always have along the line, not only for eating disorders, but for behavioral health in general. So one thing that we are trying to address this is to create a more transparent and more thorough registry for all the eating disorder treatments in the States, which are currently not available. So hopefully this sort of information will help clinicians with their referrals. So for example, if they don't have the capacity right now, they could have a safe, recognized place that they could refer their patients to. And this will hopefully connect our families to find the right type of care they need. This is also really important because a lot of the treatments are not being regulated by the states. There are not a single standards being established in the states. And we think that this piece of information will be really helpful for both increase the capacity and also just connect all the dots that we already have. And other than this, a lot of our recommendations are focusing on early prevention and intervention. So this will hopefully help us to control the case before the symptoms reach to a more severe stage that are harder for treatment and recovery. I hope that answers your questions.
Thank you, Howard.
Yeah, great presentation. Thank you. I just want to inform you of another resource. Connecticut Children's about 3 to 4 years ago opened up the state's first medical psychiatric inpatient unit. And that initiative was a direct result of the increase of number of kids coming into the hospital, particularly during the pandemic, with acute eating disorders that resulted in them requiring immediate medical attention before their behavioral health issues could be addressed. And what we found is that without an integrated inpatient unit, kids would spend 3 to 4 weeks getting their medical care and then have to wait another month before they could find an inpatient behavioral health program, usually, to Rep. Ixom's point, out of state. And so Connecticut Children's did set up the first integrated inpatient unit that specifically addresses kids with acute eating disorders. And I just want to make sure that that's on the, on your radar in terms of promoting resources and promoting it as a model that we really should be looking at in terms of adopting throughout the state and other inpatient services. But another to the point that's being made about workforce. One of the things we also found was that in addition to the limited number of residential partial programs in the state, the workforce that exists now have not really been trained to deal with the unique needs of kids and adults with significant eating disorders. So it's one thing to say, it's great that we're saying we're going to do screening and identifying all these people, but do we have the resources, do we have the networks and the competent networks that are available to provide the actual treatment for the spectrum of disorders that are associated with eating disorders? And also to recognize that eating disorders is often a comorbidity. There is a comorbidity attached to it of other psychiatric conditions, other medical conditions. So it is a very complex condition that requires specialized training, specialized attention. So my question is, as part of the recommendations, might we also think about recommending additional assistance to our training programs, both in medicine, psychiatry, clinical social work, psychology, the whole gamut, so that we can be proactive and providing the necessary training and guidance to the workforce so that we can be certain that we have a competent network of care available once our individuals have been screened and identified. Thank you.
Thank you so much for that. And I totally agree. It's way more complicated than I think it sounds when you really live it and you understand that first the eating has to be stabilized. The mind is not working properly, even to take some of the support that it needs. And so it's a very complicated process and it requires a lot of people really to do it well. And I think, but I'm glad we're taking this on, that we're starting to look at it, but it is a very complicated one. I think that training piece is incredibly important. Alice, can you?
Thank you. I want to repeat, Howard and Jeff said things that I want. I did text my executive director over at the clinic to ask about eating disorders and the referrals. And frankly, for Medicaid patients, which the majority of our patients are, the waiting list is months and months and months. And a lot of the private equity groups or private providers are not, serving kids with that. So I think, it's one thing to start screening, but then you've got a whole bunch of kids who you can't really refer. So I think that, this is always the, chicken or egg question in Connecticut is, do you screen for it, like PTSD for children, and then, you don't have enough resources. We have had some very successful movements in the state around trauma-informed care and rollouts with learning collaboratives. And, I think that it would be well worth a conversation with some of the child guidance clinics as well as CHDI around how they've been able to bring a workforce up to speed in lots of different areas. So I think that is really useful. Having been a clinician in a school-based health clinic, I know that I was required to teach health classes for kids, and the curriculum for eating disorder would be really great if there could be some work with the with DPH around what is the curriculum for the school-based health clinics, what are they required to teach, and to see if they have a curriculum for eating disorder, as well as, if not, could you help them develop something like that? I think that would be a good early intervention and prevention. Often the teachers are in the classroom, usually it depends. But I think that that's good. And the only other thing I want to bring up is that, it's been a long time, and since I've been a clinician, but I do have to say that in a typical child guidance clinic, and we've designed our own model for autism, right? That when you have a specialized population, you need to have a specialized staff model, which, if you're not going to have your staff being able to take any client that comes in, it becomes more expensive. And so we just want to make sure that there's attention paid to that. But also, I don't know what the current treatments are, but I'm wondering if group therapy is one of them. And the amount of reimbursement from Medicaid for group therapy is $35 an hour, or however long the group is. And that is just very low. And when you have a private company, of course, they're charging hundreds of dollars, So it's you have to think systemically too about how do you both bring in a trained workforce or trained workforce, as well as how do you provide the economic structure for that to be able to be realistic within our current behavioral health system. Thank you.
Thank
Thank
you
you,
so
Alice. Senator Mar?
Thank you. First off, thank you so much for the presentation. It's the second time I've heard it, and it strikes me continue again how important this is, how important this conversation is, because this is something that goes undiagnosed frequently and has impact on children and families' lives. I also am struck when I was listening to the remarks of Representative McCarthy-Vahey, and she made a very good point about the fact that you're going out and presenting this to public health, to education, to try and build traction around the issues, which makes tremendous sense. I have a concern that we are the Children's Behavioral Health Committee, and while we may need to refer some of our legislative processes to other committees, I want to make sure that we don't get siloed into other committees and get diffuse when addressing this issue. That this is why we're here as the Children's Behavioral Health, and that's what we need to do. So I just want to put that point on it, that this is something that if we're going to take it up, we should be taking it up and then refer to other committees as necessary on some of the recommendations. So thank you very much again for the presentation.
Thank you, Senator Mar. Any other comments? Yes.
Thank you. Excellent presentation. It was very informative. Thank you so much. I just have a quick question about the mortality data. Is there a breakdown in terms of how many are related to medical issues and how many are related to suicide?
Thank you so much for asking this question. Unfortunately, I don't have the data on hand right now, but I can definitely look into that and get back to you. But I would say that physical cause of death is is at the highest priority. Is at the highest risk for eating disorders. Most importantly for anorexia nervosa.
Remember being really surprised to hear that of all the behavioral health issues with children, that eating disorders and anorexia was at the top, and it was terrifying because I was dealing with a loved one with that. And I will say, I think another piece that's really important, and I think it's addressed with the 211, is really for parents to have a place to reach out, because early on you don't know what you're seeing. It's hard to know. Especially when it hits around adolescence, right? Is it that they're growing? Is that they're like, you're not necessarily sure what you're seeing, because it's not all of a sudden that someone stops eating. It's more of a gradual process that can happen right in front of your eyes. So I think that's another piece that I think I see the most under the 211, but we may need to think of a way when the information is going out to, say we do it with the schools and all that, it really needs, the parents need to kind of see it too, to have a level of awareness. It's just something I think is largely unknown to people if they don't have this come into their lives, which I would not recommend. Any other? Okay, yes, Rebecca.
Hi, thanks. And actually, to that point, I was going to ask if Thomas and Tiana, if you know any good organizations that do a really good job with educational programs for community and schools. I work with middle and high school parents that bring events to our community around mental health and wellness issues for families. And this prevention and awareness piece would be great to know what you might recommend if you have, or if anybody has groups that you could recommend that have presentations to bring. Yeah. The other question I wanted to ask, just while I'm at it, sorry, is it's just about older teens and just looking at that, the number going from 12 to 25, right, is the age when eating disorders really start to blossom. That's a terrible word, but those older students, older children who are the post high school grads, they're leaving the home, they're going off to work or college, and they're becoming more independent, and they're dealing with, they can get into eating disorders. I can attest to that personally. And just the supports or the awareness and prevention around that, what maybe it's out of your purview in terms of age range, but just that phase is what concerns me too.
Thank you so much. So first, for the education piece, we do have a list of existing models and materials that we didn't have time to share during the presentation. But for example, on Harvard Striped, they have a semester-long course for eating disorder prevention that's being tested and adopted by many schools around the globe. And there are also other models that we can incorporate and adjust based on our needs. And the second piece, thank you so much again for raising our recognition. So what we can do for the states is to have a more established network for community side of the support. So if they are not getting the information in high school, hopefully we will have more support for them in our community. Yeah, and we will love to share our slides and also our prepared list for community organizations and treatment facilities later on.
If I can just ask for a follow-up request, one thing that I'm reflecting on here is that eating disorders are not contained to only children. They're lifespan issues that people deal with. And I imagine that there's going to be different pieces of policy that address older adults that have eating disorders and some of the restrictions, as opposed to children and the mental health angle. And I think what our committee at TCB has really tried to stay true to is the specific policy interventions that impact children's mental health. So children being the focus. I would love if you could take the recommendations that you've presented here and sort of distill down those that you believe have a closer nexus to children's mental health. I think the school-based ones, I think the age restrictions, yes, but I also see another large subset of the recommendations being full lifespan recommendations, and maybe those aren't as appropriate for TCB. So if you would be willing to do that sort of follow-up exercise before we have to formally ratify any recommendations, I certainly would appreciate that.
Absolutely, we'd be happy to work on that.
Lena?
Yes, hi, thank you so much, Dr. Nusho and Dr. Sang. Do we have any data for children that they have a refusal to go to school with the eating disorders? because what I can see is that a lot of the times the parents has to go there to the database, and they are on the daytime, then um, they had to go there. Of course, the children has to miss the school, and then we have like a little conflict sometimes between the school and the parents and the child, because sometimes of course there are so many issues that they don't want to go to school. Then I would like to see, how we can make this better, for the family, for the child, because at the end, as a parent, we all what we wanted is that our child had the same opportunities to get the proper education like any other child. Thank you.
Thank you for your question. So the data piece is always a question through our research process. So we do share some information when it comes to inpatient data, but as we can see throughout the presentation, we didn't have any other data for the states when it comes to eating disorders, because it's so under-recognized, and it's just hard to capture all the nuances for this disease. So currently, unfortunately, we don't have anything targeted towards this group, but I would definitely take a more thorough look into this, and we would like to hear any recommendations alongside of this specific group. But thank you.
Lorna? Thank you, and I echo, again, wonderful, excuse me, presentation. What I greatly appreciate with what you've shared is how you were clear in acknowledging that when it comes to this topic, it does not discriminate based on race and cultural backgrounds. And as we know, for many, many years, when it came to presenting information about eating disorders, persons from diverse backgrounds, in particular the African American community, were used as a point of reference to highlight where it was less than occurring in comparison to those from Eurocentric or European backgrounds. And what you've shared clearly acknowledges that it is something that, again, it is impacting Black and Brown communities as well. With that, a question I have, and you likely already are touching on this when it comes to promoting more screenings. It's also important the metrics that are used with the screening tools, because different Black communities respond to questions differently. And so I just encourage for that to be something to be recognized as well, how questions are asked or what questions are asked in and of themselves, because different communities may respond differently. And also with that, in terms of the psychoeducation provided to communities and families, how there's not one size fits all. And so we've heard wonderful examples here today and here in this room of parents that are supportive and encouraging of their children who may be experiencing these challenges. However, there may be some households where the response may be, say, what? What is this? And may reject the notion that there may be a challenge. And so that level of communication would have to be modified and specific to that family. So again, thank you so very much for bringing this up. Thank you so very much for expanding the conversations on it. We certainly look forward to seeing how it will continue. So thank you again.
Thank you.
Thank you. Are there any other comments or questions? Oh.
Just a quick one. Are we aware of, or is somebody aware of, because I'm not aware of, any international and any other countries that have kind of built a system that is a little bit more robust from what we have, right? In terms of the prevention, I think that's critical. Really kind of helping kids with healthier development of their bodies, their nutritional awareness, their general sense of health, right? Who's doing it better? And is there stuff that we can borrow, right? So, and the other thing I just wanted to reiterate is for the deeper end, the kind of lack of, over the course of the years that I was involved in doing direct advocacy for a lot of families who are looking for stuff, the fear that exists in the medical community and in the mental health community of kind of trying to manage it alone, right? So go to Howard's point, the integrated nature of the problem is critical, that it has to be, you know, kind of the blending of the knowledge base and experience of both. And maybe then we would have a better chance of more effective treatment.
I really appreciate that. And because I've seen that work and I didn't see it work in any other way, I can attest to the fact that the integrated model, I think, is really the only way it can work really effectively. And I will say, you know, sometimes it is what we could do differently. Like we can look at social media and those pieces there. But I did appreciate this research showed what COVID also had a role in it. And the COVID role is what we experienced, right? This would have been something, I think, raise the anxiety level to a certain extent when there was such a lack of knowing that tipped a lot of kids into an area. But I think when you can see a place that addresses the physical and the mental piece all together and physically have you there, teaches you how to eat properly. You're with other peers who are learning to eat properly, and they're holding you there until you're ready to move beyond, which in our case was 3 months and in another state, which again gets to who gets to do that? What does that look like as from an insurance perspective? Of course, the first thing they run is your insurance. We were able to do this insurance, but then you have to find a place to live. You have to find a way to move back and forth. That is not feasible for most people. And one of the things I thought was fascinating was when in Connecticut, when in Colorado, finding out as we were leaving that we have one of the top people as far as researching, literally 7 minutes from my house. Now that was at the prevention stage would have been that person, but we did have resources here that we didn't even know how to tap into. So one of the things, building that information so that we do have it, I don't think we nearly have enough, but we still should have that at our, readily available. 211 certainly didn't have that information at that time. Not a knock on them. It's just that it's difficult. This is a really hard one. But I think what Howard's raised and what you're raising, Mickey, is really the optimal way to deal with the issue, but it's very expensive, it's very complicated, and there are access points. And to what Lorna was saying, I mean, my son was seen as a unicorn. You just didn't see a little Black boy who had, these issues. And so it was very, very difficult, and I wouldn't wish it on anyone, but I'm so grateful for the treatment we received. We never had to look back, but I wish that for every child and every family that goes through this. So thank you so much for this presentation and for bringing this awareness. It's really important. People are out there struggling right now, and anything that we can do to start moving it forward is a good thing. And this is something we want to take very seriously as we look at possible legislative recommendations moving into this session. Oh, Rebecca.
Sorry, I just wanted to say one thing. You mentioned COVID, and also social media was mentioned too, as a big piece that impacts all the mental health and wellness around children. And I just wonder if this committee has any legislative power to deal with social media regulations and legislation around this. I was just listening to a podcast about an advocate who's going after the big social media companies and just getting threatened. And, it's a fraught issue, obviously, but it's huge. It's a huge impact. We come back to it all the time, I think, around mental health and wellness for children. So I'm just thinking about that piece, and I don't know if we can go anywhere with it as a group, but it would be interesting to try to think that through.
So we actually had raised a social media bill earlier this year, last year, 2025, and it died. So we would definitely love to move forward with that, with adjustment or without adjustment, but we would definitely love to have more regulation when it comes to social media content, especially the content feed that's being pushed to the individual's homepage.
Well, thank you so much. If there are no other comments, thank you so much. We really appreciate this, and we will continue to work on this and stay in touch, but I really appreciate it. Thank you.
Thank you for having us.
So,
Thank you.
yes, and thank you, TJ. We just to level set about where sort of what the next steps are, as you heard, 3 of the concept recommendations for the TCB to consider, and we still have maybe pending 1 other in the collaboration with ASDAC around exploring autism and IDD recommendations. So this is a short session. So we have to work very quickly in finalizing a language. And as Senator Marr reminded me, there are some significant deadlines coming up around introduction of these in regards to the legislative process. So with that being said, so for example, in the sense of next steps, Jason, and Alice, we will be working very closely within the next, literally within this month, to finalize the language of the cross-agency data sharing work group for TCB, as well as Howard and DCF, if we can huddle around the language about the sustainability plan, so forth, on the data quality improvement efforts for the urgent crisis care centers. I know Claudio will be talking, I know, around the exploring any additional recommendations around autism and IDD. And then TJ will be in touch with you. I think I just sent you a text too about let's debrief and set up a time to meet to go through. I think Claudio's recommendation around bucketing, taking these sets of recommendations and looking at the lifespan, which ones would be more applicable to TCB's process versus the lifespan. And to Senator Marr's point, I think one of the conversations will be meeting with the tri-chairs this Friday morning to debrief around this, but trying to make decisions around the collaborative nature with any other committees, if applicable, public health or any of the other ones that were mentioned and so forth, or how do we move these along to the appropriate platform. So we'll definitely, we have a short window to solidify these and send out drafts, a version of the language to then vote for them on February 11th. Now that I think Senator Marr, I think you mentioned the recommendations have to be made before February 6th. Is that what I'm understanding? I'm going to put you on the spot, Senator Marr.
No problem. All the bills have to be submitted prior to committee work by the 6th of February.
Okay.
But that doesn't, but I believe there might be some.
I think there might be a little bit of a wiggle room, maybe. Okay, I'll take a look at I'll take a look at the deadlines and just to ensure that the February 11th, which is the voting meeting, still aligns with any other legislative deadlines in the process, because we definitely want to make sure that this package of recommendations gets to you all. So perfect. Any questions around the process? Please, I will be in touch with individuals around narrowing and refining the language and putting that package together. Any other questions around that? All right, I think that concludes our meeting for today. Emily, is that correct? Yep. Okay, so our next meeting will be February 11th, and really appreciate everybody's time today. And again, enjoy Happy New Year, and we're looking forward to a strong 2026. Thank you, everybody.
Thank you.
You.